as I'm a F1 based in Stoke, and Harry, you can introduce yourself.
Yeah, hi guys. I'm Harry. I'm an F1 based in Hereford. So today we've got surgery. So we've got 14 questions on. It's quite a big topic, so we try to go to sort of the important things. Same as the last few sessions, we'll do a question with polls, give you sort of 45 seconds to a minute to answer those questions, and then we'll go through the answer and the explanations, and we'll do it that way. As always, slides will be available and recordings will be available after the session, and we'll post a feedback form as well at the end of the session as well. Any questions, just pop them in the chat or shout out, feel free to. So, all right, let's make a start with question 1 then. So,
have they got the interactive link?
Yeah, so I'm just going to do the polls. So, yeah, they've got it. So,
okay, fantastic.
So, question 1: 60-year-old man is admitted to hospital unwell. On examination, he's got right upper quadrant tenderness, and he's Murphy sign positive. He's not jaundiced, and he's afebrile. Imaging shows a normal caliber bile duct and no stones in the gallbladder. So, what's the most likely diagnosis? And as you may know, the poll is completely anonymous, so put whatever you think. Okay, so we've got one response. Okay, next slide, please. So, yeah, the answer is A, acute acalculous cholecystitis. So, the trick in this question is you can get cholecystitis without the presence of stones. So, acalculous cholecystitis would be a stone that's impacted either the neck of the gallbladder or in the cystic duct. And that's where you get your bile stasis, growth of bacteria, infection, whereas acalculous, there's no stones, and it's usually due to severe illness. And as I'm sure you guys may know, in cholecystitis you present with right upper quadrant pain, fever, and you're also Murphy sign positive. And Murphy sign positive is when you place your hand under the patient's right costal margin, you get them to take a deep breath in and out, and what happens is because your gallbladder is attached sort of inferiorly underneath your liver, when they breathe back out and the diaphragm relaxes, their gallbladder catches on your hand, which is why you get that sharp, intense pain. So typical investigations you'd want to do is your standard bloods, FBCs, LFTs, UNEs, CRP, coag, particularly if you're thinking about taking them to theatre. So an ultrasound would usually be the first line, ideally within 48 hours of presentation. And treatment would be cholecystectomy. Quite commonly it's done laparoscopically, so take the gallbladder out. Okay, next question. Next slide, sorry. So just don't want you guys to get confused with ascending cholangitis, which presents with fever, right upper quadrant pain, but also jaundice. And we're sort of moving away from Charcot's Triad to now Raynaud's Pentad. So that presents with confusion, hypotension, and the difference is in cholecystitis, where you get blockage in this yellow tube here, the actual cystic duct. Cholangitis often presents in the common bile duct, which is why you get these slightly different symptoms. Cool, and next slide. So, next question. So you've got a 40-year-old lady presenting to the surgical clinic with bilateral inguinal hernias. She developed chest pain and suddenly collapses. So as part of her investigation, the chest x-ray is ordered, which shows evidence of mediastinal widening. So given the most likely diagnosis, what is the optimal treatment? And again, this is what they like to do with their questions, almost like a two-step question where it's not enough to just know what the diagnosis is, but once you know the diagnosis, to then be able to give the management or to give the gold standard of investigation in another example. Okay, so another 20 seconds. Okay, another 10 seconds. Just have a educated guess if you're not sure. Okay, so we're a bit split. So we've got an answer for B, an answer for D, and some answers for E. So next slide, please. So yes, so the key to this one is realising that this lady's presented with an aortic dissection, and I decided to be a bit mean because typically when we think of an aortic dissection, you get the typical presentation of a man, an elderly man in public having sudden tearing chest pain, the sudden drop in blood pressure, and the sudden collapse. So this is a reminder just to get out of the routine of those sort of clear-cut questions. So yes, you get your sudden onset chest pain in the majority of cases. In some cases it can be painless, but they'd be very mean to do that. You'd usually look for more typically hypotension, but there can be hypertension presenting. But what's more important is if in the questions then they talk about a difference in blood pressure in each arm of more than 20 millimeters of mercury, then that should hopefully set off the light bulb for this might be an aortic dissection. So typical features you'll see in an x-ray is a widened median sternum, the abnormal aortic knob, which we'll go over in a second, ring sign, and also deviation of the tracheal and or the esophagus. Further imaging you'd want to maybe do is CT angiography, and you can also do MRI angiography. So if you go to the next slide. So hopefully in the top we can see the CT scan. You can see this creation of the false lumen that you see in aortic dissection. Quite clear here. So you've got your aortic ascending aorta here, and your descending aorta, which is a small one at the back near the vertebrae. And so when you're sort of looking at CT scans, you can sort of use these two as your landmarks. So your ascending aorta, descending aorta, and your pulmonary trunk in the middle. According to where the aortic dissection is, will also determine management. So I'm sure some of you may have heard of the Bakey classification or even the Stanford classification for aortic dissection. So you have type 1, which involves the ascending and descending aorta. You've got type 2, which involves just the ascending aorta. And you've got type B, which involves just the descending aorta, and this happens after the subclavian artery. So typically in type A, where there's ascending aorta involvement, your patient is more unstable, so you would want to do surgery, in this case an aortic root replacement, replace the valve, replace the artery. Whereas in type B, they're usually more clinically stable, so you're able to treat medically with antihypertensive medication. This is a really important, almost a surgical emergency, if you will, due to the high mortality rates if this is not picked up quite soon on admission. So it's a really important one. Okay, next slide, please. Okay, so question 3. A woman is admitted with a 48-hour history of worsening right iliac fossa pain. She's been nauseated and she's had 2 vomiting episodes. On examination, she's markedly tender in the right iliac fossa with localized guarding. Vaginal examination is unremarkable. Urine dipstick is negative. Blood tests show a white cell count of 13.5 and a CRP of 70. So what investigation do you think will confirm diagnosis? Okay, another 10 seconds. Okay, 5 seconds. Have a guess if you're not sure. Okay, so again, we're a bit split. Some for A, some for B, and some for E, which is always good. So hopefully most of you, if not all of you, will be able to recognize that this is quite clearly an appendicitis. We've sort of ruled everything out, so the pregnancy test is the big one, especially in a woman of childbearing age presenting with abdominal pain. So if we go to the next slide, please. So appendicitis typically does not require any imaging and is a clinical diagnosis. So a number of sort of presentations, hopefully most of you are familiar with the classical right iliac fossa pain, and that's due to the localized inflammation. You might have 1 or 2 episodes of vomiting. Usually people will present with a fever and increased inflammatory markers. So there's a number of different clinical signs. Hopefully most of you have heard of Rosling sign. So you palpate the left iliac fossa and you get rebound tenderness in the right iliac fossa. You've also got psoas sign, which is extension of the thigh, and you turn that laterally and that causes right iliac fossa pain. And again, that's irritation of the local tissue. And we've also got obturator sign, which is internal rotation of a flexed right thigh. So even though it's a clinical diagnosis, you can do sort of further ultrasound imaging to sort of rule out your other differentials. So things you might see is a non-compressible appendix, an appendicolith presence within the appendix, and you might also get thickening of the walls. Okay. Next slide, please. So differentials, so mesenteric adenitis, similarly presenting with can present similarly to appendicitis, but usually more sort of generally unwell. So things like sore throat is a big one in questions. Meckel's diverticulitis, again, similarly to diverticulitis, happening more in younger kids, but you would also get rectal bleeding. Gastroenteritis could be another one, but typically it's a more generalized symptoms. It could be a UTI, but again, no urinary symptoms. Again, pregnancy is a big one. Someone's put in the chat about whether it's not ovarian torsion. So the way I understand it, ovarian torsion usually is more severe, sudden onset pain, and nausea and vomiting is usually accommodated with the pain. And what you have is this pattern of waxing and waning of the pain. So pain sort of comes and goes in waves, whereas appendicitis is more of a sort of constant pain. So ovarian torsion is a very good differential as well, which I did include in here. Treatment would be a laparoscopic appendectomy. Again, in general surgery, laparoscopic approaches are becoming a lot more popular due to being less invasive and better recovery. Something that I have seen a couple of times come up in my finals, I'm not sure how much they'll go into it, is to just be familiar with your different incisions and what the type of incision, and also what operation that would relate to. Not only could that come up in your written finals, but in ISCIs, OSCEs as well. And if you can say that he's got a certain type of surgical scar and allude to what might have been the reason for that, what operation, and that will look a lot better. We don't have enough time to go into each individual one, but hopefully that will, when you get the slides, you can have a look at that and sort of do a bit of your own reading about that. Cool, let's have a next slide, please. So, question 4. So a 75-year-old lady is admitted with a large bowel obstruction. She's investigated with an abdo-CT, and it shows an obstructing carcinoma of the ascending colon. So what is the best course of action with regards to management? So do we do a right hemicolectomy and ileocolic anastomosis? Do we do an ileocolic bypass? Do we do a loop ileostomy by itself? Do we put in a self-expanding metallic stent? Or do we do a subtotal colectomy and take everything out? So again, another tricky one, but definitely something that I've seen come up. And really this one just relates to your anatomy, which I understand is taught variably well based on which university you've gone to. Cool. Okay, another 20 seconds. Okay, so most people have gone for A, so next slide please. Good. Yeah, so this, well done for those who got it right. So it's basically a question of the anatomy. Where is the sort of cancer, and what and what would you do with regards to that? So essentially, if you've got site of cancer in the right colon, you want to do right hemicolectomy with an ileocolic anastomosis. So connect the ileum and the colon. If it's in the transverse colon, then you want to do an extended right hemicolectomy, and again with an ileocardiac anastomosis. Now, if it's at the splenic flexure, so the top right of the colon, again, extended right hemicolectomy. Now, if it's in the sort of distal part of the splenic flexure, then you want to move to a left hemicolectomy with a colon anastomosis. And as you go down to the left colon, same thing again. Now, when you get to the sigmoid colon, down towards the bottom, that's when you want to do a high anterior resection. When it's the upper rectum, you want to do just an anterior resection. So it's when the sigmoid colon part of the rectum are removed, and if it's in the lower rectum, just an anterior section, and the angel verge, an abdominoperineal excision of the colon and rectum. So essentially, what you want to do is wherever the cancer is, take as little of the bowel as you can out, and then you want to anastomose, which basically means connect the two ends together. So this one is just about learning your anatomy. If you know where the cancer is, that's the part you want to take out. So next slide, please. And just a quick word, it is quite common. Hopefully you guys learned it by now, but small versus large bowel obstruction, things to look for on abdominal films. So your large bowel obviously has a much larger diameter than small bowel. Now the position of the loops, small bowel essential and large bowel peripheral, hopefully that's fairly self-explanatory. Small bowel usually has a smaller number of loops than the large bowel. Fluid levels is few on the large bowel than the small bowel. The abdominal markings, the valvular conaventes versus the haustra, the way to sort of tell the difference is the valvulae in the small bowel on the left side. It's not the best diagram to see, but they sort of span the whole diameter of the bowel, whereas the haustra, which is hopefully a bit clearer to see, only partially across. So for me, that was a very easy way to tell whether you're looking at small bowel or large bowel. So diameter, the valvular conaventes versus the haustra as well, and the size of the bowel. Just bear with us 1 second. Cool. Next slide, please. Okay. So a 38-year-old man is admitted with an episode of sudden collapse and a passage of melena. He's been suffering from postprandial abdominal pain for 3 weeks, and this is most marked several hours after eating. So what's the most likely cause of his bleeding? Is it duodenal ulcer, gastric ulcer, is it stomach cancer, is it varices, or is it a Mallory-Weiss tear? Okay, another 10 seconds. Cool. Next slide. So, yeah, there's the answer. Guess duodenal ulcer, or Newton's duodenal ulcer, should I say? And yes, the difference between duodenal and gastric. Duodenal is pain postprandially after eating, whereas gastric is pain when eating. So, duodenal ulcers are also most commonly present in the first part of the duodenum. And so what we've got here is an upper GI bleed because of the passage of melena, secondary to a duodenal ulcer, which is quite often the case, and you'll probably see it a lot when you guys graduate and start working. So upper GI bleed, you want to look for hematemesis and or melena with a sudden collapse. And there's a number of different reasons for bleeding. Esophagitis, a Mallory-Weiss tear, which usually is associated with someone who has a tear by repeated coughing, can always be cancer, and also in this case, it can just be gastritis, or it can be esophageal varices. So next slide. So if you've got someone who presents with upper GI bleeding, most trusts have sort of care bundles or pathways to follow, but especially for the for OSCE scenarios, if you have someone that presents with upper GI bleeding, generally what you want to do is assess for hypovolemia, so a tachycardic hypotensive patient. If of course there's visible blood loss, both mouth and the back passage, so you will need to do a PR exam, and also review medications. So things like NSAIDs, steroids increase risk of developing ulcers and subsequently path ulcers which bleed. And as I said, most trusts have a sort of care bundle, and the general principles of care bundles are, first of all, to rehydrate the patient. So IV access, usually 2 cannulas, wide bore green cannulas, start them on fluids. While you're there, FBCs, Usinese, LFTs, coag, and a group and save, because quite often you will need to scope this patient to find the source and, if needed, stop bleeding. You also want to give IV PPI as, again, a form of gastric protection. Stop any medications which may be contributing to someone's ulcer in this case. Stop any blood thinners. You also want to calculate something called the Glasgow-Blatchford score. And again, you want to consent the patient for an endoscopy to try and find the source of bleeding. So next slide, please. So the GBS score is a sort of risk stratification for upper GI bleeding. And as a general rule of thumb, I believe it's 50% of, that's it. So people who score 6 or more are usually greater than 50% risk of needing some sort of intervention. So you want to check the hemoglobin. You want to check their urea, their systolic BP, if they're male or female, the heart rate. So again, this idea of hypovolemic shock, if they've got melena, if they've had recent collapse, any background of hepatic disease, and if they've got cardiac failure. And that would usually risk stratify as to how stable your patient is and whether they'd likely need intervention. Cool. Next slide, please. Okay, so question 6, my penultimate question. So you've got a 70-year-old female presenting with a painless breast lump. Clinically, she's 4 centimeter diameter, irregular right breast mass with no other palpable masses. What is the most likely lesion? So is it an atypical ductal hyperplasia? Is it DCIS? Is it invasive ductal carcinoma, invasive lobular carcinoma, or is it a lobular carcinoma in situ? And again, another sort of tougher question. Okay, another 10 seconds. Have a go if you're not sure. It's all anonymous. Okay, so we're sort of A, B, and C is what we're thinking. So we're sort of heading in the right direction. So next slide, please. So in this case, an irregular breast mass in the right outer quadrant is usually an invasive ductal carcinoma. This is the most common form of cancer in older postmenopausal women. Hence, was mentioned in the question stem with a lady who's 70 years old. And invasive means cancer spread into the surrounding breast tissues, and ductal, the cancer has originated in the milk ducts. So you usually get swelling of all or part of the breast, skin irritation, skin dimpling, or the sort of purple orange texture you see. Breast or nipple pain, you get retraction of the nipple and also discharge, redness, scaliness, thickening of the nipple or breast skin, and you also get a lump or swelling in the underarm area. So even though this was in the question stem, this is more of a recognition of what would be the most common cause. Because again, with these questions, stick to what's most common. Next slide, please. So another thing that I just want to quickly go over is treatment, because treatment can be quite confusing as to radiotherapy, chemotherapy, mastectomy, wild local incision. So as a general rule of thumb, mastectomy would be for your worst cancers and wide local incision for your sort of less aggressive cancers. So mastectomy would be a multifocal tumour, whereas wide local incision is a solitary singular lesion. Mastectomy would be a more central tumour, where wide local incision, like in this case in the question, would be a peripheral tumour. Large lesion versus small lesion, whether the ductal carcinoma is more than 4 centimetres or less than 4 centimetres. Now, with wide local incision surgery, all patients should receive follow-up with radiotherapy. However, if the patient is a young female, then usually they'd follow up with chemotherapy after surgery. And you may often also see questions with regards to the correct drug treatment. So as a rule of thumb, you would use tamoxifen in estrogen-positive premenopausal women. You would use anastrozole in estrogen-positive postmenopausal women. Just be aware that there is an osteoporosis risk with using anastrozole. And you'd use Herceptin, or you might see it being called trastuzumab, in HER2-positive breast cancer women. So as a rule of thumb, if the worst cancers are mastectomy, the less invasive cancers are wide local incision. If you've got a premenopausal woman who's estrogen positive, you want to give tamoxifen. Postmenopausal, anastrozole. HER2 positive, Herceptin. So hopefully her and her, you can put 2 and 2 together. If they're an older lady, after surgery, give radiotherapy. If they're a younger lady, after surgery, give chemotherapy. Okay, and next slide. Cool. So this is my last question. So we've got a 60-year-old male presented to the GP with a lump in his groin. The GP examines the lump and notes it protrudes more when the patient coughs. Taking into account this guy's age and the location of the lump, the GP makes a diagnosis of a direct inguinal hernia. So through which of the structures has James's bowel travelled through to be classed as a direct inguinal hernia? Is it through the deep inguinal ring, the femoral canal, Hasselbalch's triangle, or the processus vaginalis? So again, another tricky one with inguinal hernias, but again, another common question and another test of anatomy. So another 10 seconds. You can have a go if you're not sure. Okay. So we've got majority for A and we've got some for D. So next slide, please. So in this case, so the answer is D, Hasselbalch's triangle. Sorry, my computer is just playing up. So the difference between indirect and direct inguinal hernia. So first, inguinal hernias occur when or any hernia by definition, is when part of the abdominal viscera, any of the sort of abdominal contents, protrude through a cavity or a hole. So umbilical hernias, femoral hernias, for example. Now, the difference between a direct and indirect hernia is so the direct in the hernia goes through where the peritoneal sac enters the inguinal canal through the posterior wall, directly through the wall, whereas an indirect hernia, the peritoneal sac goes through the inguinal canal and goes through the deep inguinal ring. Okay, so that you need to know, again, this is quite tricky with the anatomy, but you need to know your sort of borders of the inguinal canal. So the anterior wall is your internal oblique muscle and the aponeurosis of the external oblique. The roof is your transverse fascia and also your internal oblique. The posterior wall is your transverse fascia as well, and the floor is your inguinal ligament. So if we go to the next slide. So in a normal patient, you can see the peritoneum, you've got the inguinal canal here, the abdominal musculature here, and we can see this cavity right laterally to the epigastric vessels. So in inguinal hernia, hopefully you can see the contents of the peritoneal sac go lateral to the epigastric vessels through this gap here, and it goes through the inguinal ring. Okay, so you're going through the inguinal ring, whereas direct hernia, you're going medial to that gastric vessels and you're going straight through the wall. You're not going through the canal, through the cavity, you're going straight through the wall. So what you get is the same sort of outcome. You get hernia, you get protrusion of the peritoneal sac through the abdominal wall, but the means by which it happens are slightly different. This is probably the best diagram that I could find that helped me get my head around the difference between direct and indirect inguinal hernia. So again, just to clarify, direct inguinal hernia is caused by the abdominal contents going directly through the posterior abdominal wall, whereas the indirect hernia is caused by the contents of the abdomen going through the inguinal ring. So another big difference to differentiate direct and indirect inguinal hernia is if you put pressure over the deep ring in a direct hernia, it does not reduce the hernia because it goes nowhere. It doesn't go through the inguinal ring. Whereas on the other side, the indirect hernia, which goes through the deep inguinal ring, it is reducible. So that's another big difference there. Your indirect hernias are bit more of an emergency as well, as they're more likely to strangulate compared to direct inguinal hernias. So I hope that makes sense. I hope you can a bit more confidently differentiate between an indirect and direct inguinal hernia. Of course, there's more, such as umbilical hernias, femoral hernias, more common in women. That's something to go away and look at. Okay, I think that's me done.
Thank you, Harry, for that. I'll do my questions now. So, Harry, I know you can do the quiz. I'll just read it out. So,
Yeah.
38-year-old woman presents to A&E with severe, sharp pain in her right flank, which radiates to her groin. The pain appears to come in waves, but is described as 10 out of 10 in severity at its worst. Pregnancy test is negative. Urine dip is positive for blood, leukocytes, and nitrates. So, what would be the ideal investigation? Abdominal X-ray, ultrasound KUB, CT abdo-pelvis, CT KUB with contrast, or CT KUB without contrast. So I'll give you a minute.
So 50-50 D&E.
Okay. So the answer is E. It's a non-contrast CT-KUB. So I'll explain that. Let me just explain it all. So for those, you would have picked up that it probably was renal stones or renal colic. So I've got this diagram to somewhat explain it. That is a stone that exists in the ureter or in the kidneys. And normally the stone is, greater than the diameter of the ureter or, the kidney structure, so it can be quite painful. That's why you get that acute pain. Also with loin to groin pain, you're thinking of renal diseases with that. So you're not quite thinking of a UTI or pyelonephritis because of the severity of the pain. And also there's no fever in the history. So in terms of management for renal colic, it's pain management. So the first part is pain management. So NSAIDs is typically what you normally use. I think they tend to lean towards diclofenac because ibuprofen can increase cardiovascular events, but any NSAID is fine. You can also give alpha blockers that causes smooth muscle relaxation, so less compression of the stone. So you've got your investigations, of course, your UNEs, your FBCCRP to rule out infection, calcium urate to just understand the nature of the structure. So the reason why it's a non-contrast rather than contrast is contrasts tend to be used if you're looking for abnormality structures in vascular structures, so looking for clots, or sometimes we do CT heads, you do contrast there. Now you could say, why not just do contrast anyway? Contrast can actually worsen renal function, and I'm not saying this patient had AKI, but because there's a renal colic, I'm sure there's some sort of kidney impairment with that. So renal colic or renal stones, you're looking to non-contrast CT-KUB. In terms of treatment, depends on where it's localized. This is just a matter of memorizing it at the end of the day. So if it's in the kidneys, if it's less than 5 millimeters, asymptomatic, you don't do much. 5 to 10 millimeters, you do shockwave, lithotripsy, and then 10 to 20, then you're either thinking that or doing a uretoscopy. Yeah, so we'll move on to the next question. So, question 9. A 65-year-old man presents with lower urinary tract symptoms. For the past few months, he has problems with urinary urgency and has had several episodes of incontinence where he could not reach the toilet in time. He describes good urinary flow with no hesitancy or straining. Urinalysis and prostate examination are unremarkable. Which of the following medications is most likely to help alleviate his symptoms? Is it an alpha blocker, 5-alpha reductase inhibitor, antimuscarinic, desmopressin, or loop diuretic? So I give you 45 seconds. What we got for answers?
So everyone that's answered has selected C.
Okay, maybe this question is too easy then. Yep, so the answer was C. You give an antimuscarinic, you give oxybuteny. So let me just run through urinary incontinence. It's quite simple, I find, but it is a common thing that can come up in exams, so do revise it. So there's different ways to class urinary incontinence. You've got overactive, stress, and overflow. So overactive is increase in the detrusor activity. So I don't know if you can see my mouse, but on the top right is, structures of the bladder. That what surrounds the bladder is the detrusor muscle. So because you're getting an increase of that activity of that muscle, you get the urge of needing to go. Some patients may not complain of actual incontinence, but they may complain of needing to go to the toilet often. And when they do go, they're not actually urinating that much. Stress it's in the name. Whenever you're in a stressful or increased stress upon your bladder, then patients get leakage. This is common in postmenopausal women, where they have a weakening of their pelvic floor muscles. So in the diagram below, these structures that are towards the neck of the bladder or the sphincters of the urethra, that is kind of where the pelvic floor muscles, they sit and support the bladder. So because you get a weakening of that, therefore the sphincter muscles and the muscles there are not as strong to retain urine in the bladder. So yeah, you get an increase in abdominal pressure, and that causes leakage. So that would be when exercising or coughing or sneezing. That's when you would get these symptoms. Overflow is less common. So that's the middle one, where you get, let's say, prostate enlargements. A lot of it can be clinical at the end of the day, but you can do bladder diaries, you can do urodynamic studies. And then in terms of management, we go for conservative first, then medical, then surgical. So for urge, you do bladder retraining. That involves having diaries, recording how much you're urinating, encourage them to wait a little bit longer. And then oxybuteny is an antimuscarinic. So it activates the sympathetic nervous system or depresses the parasympathetic, therefore reducing detrusor activity. For stress, pelvic floor exercises to increase the strength, duloxetine, and then the third one is retropubic mid-urethral tape procedure, which basically is to lift the urethra anteriorly and superiorly to kind of support it up, so therefore it can somewhat, you can retain your urine. So that's incontinence. Okay, question 10. A 36-year-old male is in the orthopedic ward awaiting for fixation of a left ankle fracture. His history of type 1 diabetes, managed with basal bolus regime. His HbA1c is 32 and has no complications. His morning dose of basal bolus insulin are now due. His surgery is scheduled for tomorrow morning. He's nil by mouth from midnight. How should his diabetes be managed? Okay, so do we continue the long-acting and omit the short-acting at meals? Omit the long-acting and continue short-acting? Omit everything? Reduce the long-acting insulin by 20% and omit the short-acting? Or do we reduce the long-acting by 80% and omit the short-acting insulins? So I'll give you 45 seconds to a minute to have a think about that.
Well, a couple of people saying they can't see the slides. Maybe if you end the
I
share.
refreshed it.
Yeah.
Let me try refreshing it. Give me a second. Can you see my slides now? Is that working, Harry?
I can. Yeah, that's better.
Cool. Okay. I guess we'll give it another 30 seconds, maybe, to answer the question. And please do ask questions in the group chat if you have anything. I'm happy to answer as we go. Don't feel like you have to leave it till the end.
Okay, so most people have said A, but there's a couple for D.
Okay. So the answer is D for this one. So I used to get quite confused. There's lots of different rules for generally for preparation for surgery, and I would recommend you read. I just want to go through diabetes because I think I found this the most tricky one, but it came up in my finals. So it's just about remembering some rules, because a lot of it is actually just continue as you are, but there's just specific rules for you to actually remember. So firstly, for longer surgeries or emergency surgeries, or a patient with poorly controlled glycemic control, you normally have a variable rate insulin for them during surgery. So that's simple. But then let's just assume our patient has got good glycemic control. Here's the table I've taken from past medicine, but again, a lot of it is just continue as normal, and then we'll just talk about some specific rules to remember. So metformin in general, you kind of take it the same. It's take as normal the day before. Then on the day, if you take it BD, that's fine, continue. If you take it TDS 3 times a day, then you omit the lunchtime dose. And then that's the same for the day after. You omit the lunchtime if you take a TDS, but continue if it's just BD. Okay, and for sulfonylureas, similar to metformin, but you just omit your morning dose, and the same the day after as well. You omit the morning dose. Your gliptins stay the same. Your GLP-1 analogs stay the same. Your dapagliflozins you omit on the day of surgery and the day after surgery. Okay. Your long-acting insulins, Lantus, Levemir, you reduce that by 20%. And then these ones, and it's actually written here, but your short-acting insulins, like Novarapids, you omit them basically. Not the day before, but on the day you omit them, and then I think the day after you continue them. That's from my understanding. And then these mixed ones like Humulin 3, you don't do anything the day before. You half the morning dose on the day of surgery and the day after surgery. So it's just a few rules to remember. I know there's a lot you need to, but if you just take your time to go through this table, it's not too bad at the end of the day to remember it, because a lot of it is actually just continuing as you are. So hopefully that makes sense. I put that in because I found this difficult. I still do, trying to remember it. Okay, so question 11. A 5-week old baby boy is brought to the GP for their 6-week checkup. GP notices one side of his scrotum is larger than the other. On palpation, there is soft, smooth swelling anterior to and below the testes that transilluminates. The baby's mother thinks it has always looked like that at all times. There's no erythema or signs of infection. The baby is otherwise well and looks comfortable. Which one of the following medications or treatments is most likely to help alleviate his symptoms? So would you do an urgent surgical repair, therapeutic aspiration, reassure and surgery if not resolved in 1 to 2 years, reassure and surgery in 3 to 4 years, or arrange a routine surgical referral in 6 months? So I'll give you another 45 seconds or so. I think I ended up copying the question from the one before. My apologies, but what is ideal treatment? Yeah.
So it seems split 50-50 between A and C.
A and C. Okay. So the answer is C for this patient. It's just more, remembering what this case is. So hopefully you should have found this was hydrocele. So the presentation that I gave is actually very similar to how it would be in an adult as well. So hydrocele is collection of fluid in the tunica vaginalis, and there's it can be classed into two things, hydrocele. So one is where, especially in younger children, there can be a connection between the peritoneal sac and actually the tunica vaginalis. I don't know if you can see my screen, but you got your testes and then, oh, sorry, that's the next question. Testes, and then just around the testes or epididymis, you've got the tunica vaginalis that can connect to the peritoneal sac. So that's communicating where you've got that drainage. It's very common in young boys who are a few months old, 5 to 10%, and it normally resolves by itself. And then you've got non-communicating, which is increase in fluid production in the tunica vaginalis. So you should have known that this was a hydrocele because it was soft. It's unilateral. It can be bilateral. You can feel above the mass, and also it's transilluminous because if you think about it, it's fluid around your ball sack. So, and fluid would appear clear if you were to put a light to it. Management, it is conservative, and in adults it is conservative. You don't really do anything unless it's very long-standing. But in our case, our patient was 5 weeks. After a year or two, then you're looking to do surgical repair, and it most likely is because it's this communicating form of hydrocele. Non-communicating is not as common. So I understand maybe some people thought it was it's not urgent. I think it's just recognizing this is hydrocele, and hydrocele is actually quite common. Therefore, it's not an urgent procedure. You wait for a year or two when they're a year or two old, and then it's like, okay, maybe this needs surgical correction. Okay. Hopefully I explained that. Question 12. This is a common question. Mrs. Graham, 47-year-old female, attends A&E with a painful, swollen left calf. She had a hysterectomy for cervical cancer 10 weeks ago. On examination, her left leg is tender along the deep venous system and pitting edema is present. Examination of the right leg is unremarkable. You suspect a DVT. She's clinically stable, and the radiology department informs you it will be at least 5 hours until they'll carry out a Doppler ultrasound. A D-dimer is awaited. What is the most appropriate management now? Do you start low molecular weight prophylaxis? My apologies. B should be low molecular weight treatment. C is start a DOAC. D would be discharge and wait for the scan tomorrow. And E would be wait for the Doppler ultrasound. So in this case, let's just say B is treatment dose, low molecular weight heparin. So I'll give you 45 seconds.
So everyone has selected C.
Very good. The answer is C. So it was very obvious this was a DVT in this case, but just to explain, if you're thinking DVT, you do well score, and different things in the scoring system. I don't think you need to necessarily memorize it, but you should get an idea if someone's scoring above 2 or less than 2. But it's age, cancer, if a patient's recently had surgery, immobile for some period of time, long haul flights, those sorts of things. Okay. So then if they're scoring greater than 2, then yes, you're going to do an ultrasound. But then if you're waiting, you do a D-dimer, you anticoagulate and wait for the scan. So the D-dimer, as people would know, is an exclusion test. So if it is negative, then it cannot be a DVT or a PE. So that's why you can see on the right, D-dimer negative. You need to think of another diagnosis. Yeah. Anything else I need to explain on this side, to be honest? So in our case, our patients, because we are thinking this is DVT, this patient scoring over 2 and we're waiting, you would start treatment for this. And treatment for her would be a DOAC. One main contraindication I know for a DOAC would be if a patient is pregnant, but our patient is 47, so is unlikely to be pregnant. So if it's a provoked DVT, you give a DOAC for 3 months. If it's unprovoked, then you give it for 6 months. So for our patient, it is provoked because this patient's recently had surgery and hysterectomy. So therefore, you give a DOAC for 3 months. Okay. So yeah, just be very familiar with this kind of table. I know there's lots of past med questions on it, but it's a common question about DVT and PE management. Okay, question 13. Brian, a 35-year-old gentleman, is on the colorectal ward and has been suffering from melena for a week. His HB is 60. And the consultant has requested you to transfuse John with a unit of packed red cells. Within minutes of starting the infusion, Brian complains of itching and stinging sensations on his trunk. On examination, you observe red raised welts over his abdomen and chest. Blood pressure is unaltered from prior to the transfusion at 130/70, temperature is 37, and there is no signs of dyspnea, wheezing, stridor, or angioedema. Which one of the following management options is the most appropriate? Do you temporarily pause the transfusion, start an antihistamine? Permanently pause the transfusion, IV fluid, resus, and inform lab. Permanently pause the transfusion, IM adrenaline, antihistamine, corticosteroid, bronchodilator, supportive care. D, do you temporarily pause the transfusion, start antibiotic? Or E, permanently pause transfusion and give immunoglobulin therapy? I'll give you 45 seconds on that.
So those that have answered have all selected A.
Okay, the answer is A. Very good. So this is lifted from PassMed. I find the best way to remember the blood product transfusion complications is actually just remembering the name. And when I remember the name, then I think here are the symptoms, and therefore I understand what the management is. That's the best way around it. So, for example, our patient is having a minor allergic reaction. Okay, but we'll go through each one. So non-hemolytic febrile reaction. So it's in the name, a febrile reaction, therefore it's a fever type reaction to it. So that will be a patient who develops fevers and chills. So how do we tend to treat like a pyrexia type picture is you would stop or slow down the infusion. That means because you're giving it too quickly, you give IV paracetamol normally, you monitor symptoms, and then you may think about continuing giving the blood transfusion of the packed red cells. Then you got minor allergic reaction and anaphylaxis. They're kind of like a grading system. So a minor allergic reaction would be these, itchiness, or maybe these, angioedema or lumps, this urticaria that develops on the skin. But that's pretty much it. I know they seem somewhat like anaphylaxis reaction, but you can see anaphylaxis is far greater in terms of symptoms. So for minor allergic reaction, you would temporarily stop the infusion, give an antihistamine because it's just an allergic reaction, kind of like hay fever, and then just monitor symptoms. Anaphylaxis, that means obviously these blood products are not ideal for this patient. There isn't a matching of the antibodies, and anaphylaxis is hypotension, difficulty in breathing, you're getting wheezing, you're getting these angioedema, lumps, and flushing. That's when you need to stop the infusion. You need to do your A, B, C, D, E, and specific, for anaphylaxis is IM adrenaline with fluid resus. Okay. Acute hemolytic reaction. That's where you get more fever, abdominal pain, and hypotension. And then from there, you stop the infusion. You do your A, B, C, D, E, and then you start your fluid resus. Then you got TACO and TRALI. The way I remember it is TACO is circulatory overload. So I think this patient's got too much fluid entering their system, and that's because you're probably giving it too quickly. So they're developing fluid in parts of their body. So you get pulmonary edema, getting hypertension. So how do you treat it? You need to offload some of that fluid. So you stop the infusion or slow it at the rate that it is, and then you consider IV diuretics to treat that. Okay, and then trally, it's in the name, lung injury, acute lung injury. So therefore, I think of lung damage as a result of the transfusion. So you're getting these pulmonary infiltrates that you can see on the X-rays. You're getting a fever, you're getting chest pain, and then you need to stop treatment, A, B, C, D, E, but more commonly oxygen. So, yeah, very good job that everyone got that right. I think this is my last question. So, 34-year-old lady presents to the gynecology department complaining of heavy, painful periods and difficulty conceiving. She's concerned as she has her husband who together would like to start a family soon. On further investigation, an ultrasound scan reveals a 4.5 centimeter submucosal uterine fibroid. Which of the following treatments is most appropriate to treat her fibroids? Hysterectomy, transexamic acid, hysteroscopic endometrial ablation, intrauterine system, or a myomectomy. I'll give you 45 seconds on that.
Okay, so those have answered. Most people are saying E, and we've got a couple for B as well.
Cool. Okay. So the answer is E, and I'll walk that through why. So it is to do a myomectomy. So it's patient specific about how you go about treating fibroids. But in terms of knowing why it is fibroids, it's a benign smooth tumor of the uterus or the uterine wall, and they can be placed in different parts of the uterine wall. Features are menorrhagia, so heavy periods, and bulky related symptoms, low abdominal pain, complain of bloating, because these fibroids, they cause an increase in hormone levels. And also you may get some urinary symptoms, especially in large fibroids, and also where they could be situated. Diagnosis is transvaginal ultrasound all the time, and then management is different types. Okay, so if we are there to just treat the menorrhagia, the best treatment is the IUS system. You can use the combined pill. You can use transexamic acid. And I can understand why maybe some people thought of using transexamic acid because that's treating the menorrhagia. But in terms of definitively treating this patient, it would be more a myomectomy, because it does get rid of the fibroids, and there's evidence to show that it doesn't have too much of an effect on fertility risk. So I understand why you may have thought that transexamic acid, it's not technically IUS is most for menorrhagia, but transexamic acid, I understand, yeah, you could treat the symptoms, but we also think about fibroids. They develop over time, so we do need to somewhat treat that, and that's why you would more lean towards a myomectomy rather than transexamic acid, which would just treat the menorrhagia. Hopefully I've explained that. So our patient who wants to remain fertile, wants to have a family, you do a myomectomy, but if they don't, then you can offer a hysterectomy. You've got uterine artery embolization, but there's actually weak evidence for that to be effective, actually treating the fibroids, let alone, preventing further actually developing. So hopefully I've explained that difference, why it's myomectomy over transexamic acid. So that is all the questions. Let me stop sharing.
Cool. And I've released feedback as well to you guys, and as I'm sure you've already heard, we are trying to do some research as well, looking at UK MLA teaching at university. So there's a additional form there if you want to get involved with that, if you haven't filled it in already. And we'll hang about for a few minutes if you guys have any questions at all. If you guys fill in the feedback form, not only is it useful for us too, and you guys will learn about that when you start working, how important teaching and feedback is. It will help us for our future sessions, and also we'll be able to distribute slides and recordings and all that good stuff. Other than that, thank you guys for joining us.
Thank you, everyone. We appreciate it. How many people ended up coming? Are we able to see that or?
Yeah, I can see. So there's is 14 or 15 altogether.
Okay, not bad. Not bad at all. Are you just doing 2 teaching sessions then? Have you got more planned, Harry?
I have no idea. Okay. If you guys have any other questions, you can reach us on social media and things like that. But we'll end it here. The feedback form is there, so if everyone clicks on that, and our next session is actually on Thursday. I'm not sure what it is though.
It's neuroscience. I'm actually doing all this.
Oh yeah, of course. There you go.
Yeah.
Right. Okay, we'll end it here then. Thanks, guys.